And I know I've just seen there's a few more questions, and hopefully we'll get some time at the end. I'm just aware of time that we're going to keep going forward with our next speaker. So as I mentioned, Dr. Richard Issitt has started the journey to become a clinical informatician. He is the senior perfusionist at Great Ormond Street and is also the clinical engagement lead of Drive, which is a digital research space at Great Ormond Street. So welcome, Richard.
Thank you very much.
Perfect. He's joining us from space today. And actually today, instead of Richard just speaking, I'm going to ask you a few questions. And we'll go from there. And please do feel free to pitch in your questions as you go. I will incorporate them straight in as we speak. So firstly, Richard, can you explain your role and how you decided to move, or why you decided to move into more of the space of clinical informatics?
Well, it actually follows on very nicely from kind of the other talks that have happened so far. So I'm actually a non-clinician as it were. So my PhD is in more science rather than medicine itself. So as a perfusionist, I get involved with all the heart-lung bypass machines. So using that to keep the kids alive whilst the surgeon does their thing. So, I mean, we've been relatively, I suppose, digitally mature, you could say, in some respects for the last 20 years, collating data on a 20-second basis for the entirety of the patient's operation. But one of the things we've struggled with, and it's been touched on before, is that you can have all this data, but if you can't get access to it and you can't do anything to it, then your actual overall digital maturity is very, very low. And it's one of the things that I was looking at for a while, thinking, well, we need to get access to that data. That's sitting there, we're not using it. You know, to give you an example, we sit in front of the machines and there's about 15 different screens that you're looking at, different numbers on, different graphics. And each one of those tells a slightly different story, and it's very difficult to actually integrate all that into a usable format other than experience and kind of knowing where to look first. And so one of the things that sort of pushed me apart from the fact I couldn't use it was the fact that with everything I did, it was born about me noticing certain trends at the right time. So, and for many various reasons, you know, if you do switch off, you do miss something, you've roughly got about 30 seconds before you can potentially kill a patient. So, you know, it can be quite high pressure. So to take some of that sort of pressure off, get some sort of machine learning or even AI algorithm in the background that can sort of monitor the different trends and start highlighting these issues was kind of my first concern. And also the fact that, you know, as I'm sure certain government officials are learning at the moment, having everything coming out in Excel sheets is not always the best thing to have. So we wanted to sort of get away from that, get a nice pipeline in place so that the data coming out of machines could then be transferred into a usable format, structured format that we could then apply some, you know, proper statistical learning on. So for me, it was a case of, right, get an understanding of that. Let's go learn R first of all, a bit of Python and a bit of SQL, just to try and really sort of understand the process. I think it's great as a clinician when you are delivered a fresh spreadsheet or, you know, whatever it might be of data, but you have to be sure about this data curation, about what it means, where it's come from. And quite often that's, you know, mapping the data that's coming out in terms of, like we said about the OMOP, for example, and SNOMED CT codes and whatever it might be. And then trying to link that up so that everything is, you know, when you get that, you have confidence in the data you've actually got in the first place. The sessions we had, there was very, very limited analytics that we could use. So it was a case of, I've got to do something about this. I can't do this anymore. Let's just jump on the journey and see what happens.
Great. So you mentioned that you started, did you start then with R, Python and SQL and go from there? And I guess what type of support and like, how did you actually start then that journey in terms of how it related to your field?
Well, I mean, one of the reasons I went for the, you know, R, for example, is, you know, gosh, we've got this digital research environment, which uses R as the sort of main language behind it. And obviously, whatever else to get the data out of the structured formats in our legacy databases to link in with Epic when coming around. But one of the things I'm very keen on is keeping everything open source. And my own politics healthcare is that as much of the data should be available for people so they can reproduce it. I suppose part of this also was I've noticed over the years getting involved in research that quite often you have a very nice project and you get it written up and a lovely publication, and it goes into a journal and then it just sits there. And I've known other centres where they've done some fantastic modelling work in years gone by, but then nobody ever uses it again because it kind of gets lost. So one of the reasons of using R was to bring this sort of full circle into putting it back into the clinical setting. So using R to create shiny apps so that you can show somebody the model that you're creating at the end of the day, rather than here's a mathematical formula of the of the model that I've made, which, unless you're particularly interested in that kind of thing, doesn't really work for anybody. So it's giving that ability for other people to look at your data and work with it, rather than tell them what you did.
Great. And I don't know if you've just seen in the chat, but there is a question which kind of comes back to this data, and I guess clinicians from Ali Hosen. So talking about clinicians more broadly and having to apply centrally for data that they would like, rather than be able to build and run their own reports. Do you see this as a barrier, or are these digital research spaces changing in which maybe it won't be so much of a barrier in the future?
Yeah, for me, I've never really considered a huge amount of a barrier. I mean, I suppose we're very fortunate in the team I work with is that when somebody comes in with an audit request, we have a data lake with the sort of most common routinely collected data, so that when the pipeline and everything else, so that data can be pulled out very, very quickly. So you're not waiting around for months to somebody to define exactly what it is. That's already been done, and that's part of linking everything with the SNOMED and OMOP and whatever else. Every research project is slightly different. So what you're aiming for may be completely different to somebody else's, but you'll still have the same baseline pipeline research that you're going to take in to answer the question that you're going to. So I don't think it necessarily starts the system by having to go through, central process. In fact, actually, it streamlines it. I think we've got to remember that, in days gone by, quite a lot of clinicians, both non-medics and medics, would sort of bypass any sort of governance by purely going onto their systems and noting down what they wanted and then publishing it. So there's no approvals, there's no governance process, in place. And I think that's the way we need to think about it, rather than, do I have to apply for a project? Is that more getting in the way? Well, no, actually, it's putting preventions for misuse of data.
Mm-hmm.
This way, we're actually making sure that it's curated and it is correct. There's some sense checking going on, and nicely with clinicians as well to define exactly what it is they want. It does help, and it also helps every future research project or audit that comes along.
Perfect. And then, as you say, hopefully with these databases that are being built at all 3 hospitals across UCL, that this availability of clean and accurate data is only going to hopefully get more and more available.
Yeah, exactly.
So
and I mean,
now that you've got,
so it works out quite nicely because similar to the guys at UCL, we've got a lot of projects going on that link in with other centres around. So especially with pediatric COVID, we're working with teams over at Harvard, in Germany and France as well, that are trying to bring that data in to up the level of patients that we're seeing, so we can, rather than trying to say, well, 4 patients that we saw had this and 6 patients that they had saw that, and you're bringing in more patients. So the whole ability to map the data to everybody else's and have a common data set really does help, and it can only all of us going forward.
Great. So I guess we've got that data now. So what sorts of projects have you actually applied your knowledge to? Can you give us some examples of those?
Yeah, so for a good example is that we, like I said, we take all these different measurements during the operation. So one of the things that we're looking at potentially is the protein content of blood and the pressures that exerts. And what we noticed was that actually there was a link between the level of this and also the patient requiring renal replacement therapy on the ICU. And so what we wanted to do was to look at whether we could, predict essentially whether a patient was going to end up in renal failure, based upon a few parameters that we would take during the operation itself. And so what we did was essentially some Bayesian regression modeling that could actually fairly well predict, whether a patient would end up needing renal replacement therapy. And so the upshot of that is that I can now say to a surgeon during the operation, this has got a score of whatever it might be, we need to do something about it. So, and based on the probability, the fact of the patients needing renal replacement therapy, we can put a catheter in so they can go up to the intensive care unit, and we can preemptively start them on a form of renal replacement therapy, or at least give them supportive drugs that will stop them falling over the edge into acute renal failure. And again, the idea behind that is then if you can, prevention is better than cure. So if you can actually start preventing them from falling over that edge, it means that the patients are staying less time in the ITU, but also they're less likely to come back in future years, for chronic renal failure, or, being more of a bane on the NHS resources, simply because they've had that initial hit when they were younger. So that's the sort of things that we're trying to work on. But again, the idea of putting that into a format that we can use during the operation. So essentially using an R-Shiny app, for example, I don't know if anybody's done that, but it's a web application that essentially runs with R in the background. We've got a nice little slider so that you can take the parameters you want, move these sliders into place, and it will actually then give you the score in real time. So we can be sat at the pump doing the operation, get this score, and then use it there. So, it's just about sort of closing that circle of research, so that something that sits in a nice manuscript in the, in somebody's office for the rest of time, you actually got a way of using it.
Yeah, the actual clinical impact and the effect that patients are benefiting from this is great, especially in real time. So what would be the most important lessons that you have learned along this journey then to become into this role?
I suppose the first one is kind of a general one, is don't be afraid to ask stupid questions. And that's one of the nice things about learning the R and Python and open sourced languages, is that if you don't know what to do, Google is brilliant, because if you've asked the question, almost certainly somebody else has asked, and there's a load of communities that are there, and they're really supportive of people or anybody trying to learn, which is great. So that means that trying to take this on as a side project, or even something you're trying to learn in your own time, or the time given to you, whatever it might be, it makes it a lot easier. And that's always something that's really very useful. I think the biggest thing that I learned was actually discussing, because we work with young children, you often assume that we can't really discuss the ideas about what we're doing because it's far too complicated. And I think that's more of an egotistical thing on our side rather than the kids. Because when we actually went to them and said, look, these are the sort of things we've been doing, they came up with a very good point, which is why I got involved in Shiny, which is, don't tell us what you've found, show us. We want, we can look at data, we can understand these things, involve us in this idea. And which is where this sort of Shiny idea came about, of giving them the data set and some few tools so that they could then play with it, and they can see the graphs being made, see the visualizations, whatever it might be, and they can feel that they're learning. And also that they're getting involved in the research on their data, because that's the other thing, is that we use routinely collected data from all the patients, so it's nice for them to have, or feel that they've still got some ownership over it, rather than it just goes into a system and then clinicians use it. I think that's really quite nice. But storytelling just generally is the biggest thing. If you explain to somebody what you've done in a way that they can use it, then it becomes fairly pointless.
Great, and that can apply to children as well as adults, isn't it, across the whole age range? So yeah. So, and then the last question, just to finish up on, is obviously you're from a more clinical point of view, but I think that this could apply to anyone looking more to get into clinical informatics. If you have a more pure research or academic background as well, as what were those resources that you found really good just to start you off and going from there?
Yeah, I mean, in terms of for example, R, there's a great NHS R community that are essentially based upon health research, and they do a lot of work on that. So it's really, really good. So they're wonderful for being supportive, using different modeling, and getting involved in that sort of thing. And then you've got we talked about the faculty of clinical informatics, if I could say it, which again gives you some guidelines. I think it's probably worth saying in that respect. So I belong to a profession that isn't statutorily regulated, for example. So I don't fit their criteria as such, but they are bringing in some core competencies that you can, do so that you can fit with them. And I think that's great. So you don't have to pigeonhole yourself into certain other criteria. It can be a broad church as such. But if you NHS careers, all sorts of things about clinical informatics, and I think that there's going to be a certain group of us, I suppose, that never learnt informatics at university or didn't do those sort of degrees, but are still interested and want to move across. I think, if anything, I've learnt that actually you can do that in almost part-time, or as you can learn on your own time. You don't necessarily need to dive in the deep end and do a master's in data science, for example, although that may well become quite useful in the future.
Great. I think it's really great to hear about, as this is such a new field that is growing, how people have moved into it from different backgrounds, but also it's great to see that real life example of how it's being applied to your work. So great. If there doesn't seem to be any other questions at the moment, so I think we will, and we have shared the Faculty of Clinical Informatics in the chat. Additionally, one thing that's also happening, we've just released slots for the newest version of Clinician Coders, which is run by UCL as it is based for clinicians at the moment only, but to really introduce you to R and I believe Python. So that's run from the ACO. So do check that out as well. If that is something interested, you want to start that learning as well, which Richard has mentioned. So thank you so much for that, Richard.
No problem.